I'm gonna talk and pass the mic off to you guys, and then I think you guys have it. All right, guys, we're gonna get started here. It's 11 o'clock, so we want to make sure we have enough time for to get through this and have some questions, hopefully. So thank you all for coming. This is a great audience. This is a panel. We're going to be talking about catch and release. We're going to be talking about the possibility of ED extubations. Here's our disclosure slide. All right, let's get into our objectives. So in this session, this 20-minute session, we're going to be getting through some material. We'll try to make sure that we get all the way through all this stuff. So we're going to identify and describe the optimal patient population that's amenable to ED extubations or the potential for. We're going to describe the limitations therein. And we're going to discuss a protocolized approach to an ED extubation because that's probably necessary. This is me. I'm Alex Bracey. I work at Albany. I'm an ED resuscitationist. I spend 100% of my time in the ED.
Hello, everybody. My name is Chidima Wakama. I am here in Philly. I work at the University of Pennsylvania. I'm 100% in the ED, and today I'm going to be arguing in favor of ED extubations.
Hi, everybody. I'm Raghu Sithal. I'm an EM intensivist. I practice at Brigham and Women's Hospital and Mass General up in Boston, and I split my time between the ED and the ICU. And I'm also on the pro side.
Hey, everybody. I'm Skylar Lentz. I'm an EM intensivist at the University of Vermont. I split my time between the ED and the ICU, and at least for today, I'm going to be skeptical about ED extubation.
Hello, everybody. My name is Kane Chikwanu. I am at St. Louis University. I'm an EM intensivist there. I split my time equally between the ED and ICU, and I'm going to be arguing against ED extubation.
All right, great. So this is our panel, and let's get right into it. So let's talk about a patient that you've all had. Every single one of you has had this person come into the to the department. If you haven't, you will later on today. The person is drunk. They're on the ground. They're scraped off the street. They got a lac on their head. They got a black eye. Maybe you have a trauma service, maybe you don't. But in your place, you're trying to get vitals on this person. They're thrashing around, they're fighting you. You know what you have to do. You know you have to get this person to the scanner. You know you got to do some work on this person. You can't get anything. So what do? You intubate this person, right? And you put them through that scanner. You get the gas. You get the labs. It's all normal. Everything is normal. It's coming back normal. You repair the lac, and now it's 2 or 3 hours on. Trauma services, trauma signed out. What do you do with this person? Now they're waking up. They're looking at you right in your eyes, right in your soul, and they're pointing at the tube. Right. So we've got a choice here. We've got a choice. What should we do? Should we put this person down? Should we give them more sedative, more analgesic, make them go to sleep, make it the ICU problem? Or should we potentially extubate this person? So I'm going to pose the question to you all. What would you do in this circumstance?
So I would extubate this patient immediately. I think that the reason we should consider ED extubations, one of the reasons is boarding. How many people, can you show of hands of who has an issue with boarding at their institutions? Yeah, I thought it was just me. So I think that if we are extubating patients that no longer need to be intubated, right? So that's freeing up an ICU bed. That's another person who could go to the ICU that we could discharge this patient. And that's my favorite disposition is home. So if this patient can get out of my ED, if they're doing well, I think that improves ED flow and it improves us just moving through the ED and getting a good use of our resources and not pouring everyone's attention into this person who doesn't actually need a tube anymore.
All right, well, I've got a few things there. Now, I agree, boarding of critically ill patients is a real problem, but I'm just skeptical that extubating a few patients here or there is going to move the needle on our boarding of critically ill patients. I think if we want to be serious about this, let's look at patients we don't need to intubate in the first place. Let's use the data we do have to try to avoid intubations. That'll also help us save time if we don't intubate people in the first place. Let's take, for example, COPD patients. Let's become masters of non-invasive. Let's try to avoid intubation. Let's use studies like the HAPPEN trial that came out just a year ago that showed that high-intensity non-invasive settings may avoid intubation by going up higher on the IPAP than we used to, an IPAP of all the way up to 30. Let's get back to our case. The agitated person, right? We have tools in our toolbox to control agitation without an endotracheal tube. And we can say, well, what about anticipated course and all this? Well, I can anticipate that course. When the PAN scans come back negative, if your trauma team's like mine, PAN scans negative, dispo per ED, right? They put it back on us. Let's step in the first place and see if we can avoid it. And then the other common one, right, that we all encounter is the comatose, intoxicated, and poisoned patient that we're wondering, should we intubate for airway protection? I say we take a step back. I might be able to extubate them in 6 to 12 hours, but maybe I can just avoid intubating them in the first place. The NICO trial came out 2 years ago, gives us some good data yet again. What they did there is people with the GCS of 8 or less, instead of intubating them, they said, well, instead of your usual care, why don't you just wait 4 hours and see if you can avoid intubation? And in that study, just waiting 4 hours, this is something you can do tomorrow. We can all do when we go back to our shifts. We don't need a fancy extubation protocol. We can just try to wait a couple hours if they're oxygenating, ventilating okay, avoid intubation potentially by doing that. And in that study, they reduced their intubation rate by 42%. Their length of stay went down by 16 hours by avoiding intubation successfully in some of them. I'm not saying we can do that all the time, but with 16 more hours, I think even my buddy Raghu could see a patient or two, maybe, with 16 extra hours in an ED open bed. So I don't know. I'm not saying we can get our intubation rate down to 0, but I'm saying we could probably reduce it if we used our data, used our skill set to avoid it in some of these cases.
It's a very valid point, Skylar. And I agree with almost all of his talking points. But let's get back to the topic here. It's not a should we intubate in the ED talk. It's should we extubate patients in the ED. So once the patient has been extubated and we've already made the decision, whether EMS did it or we did it, the patient's intubated. So now let's focus on should we be extubating these patients in the ED. Emergency physicians should be masters of the airway. And that doesn't just mean putting a tube in. That means the critical thinking that goes all, around regarding intubation. We are always thinking about how do we intubate the patient? Should we intubate the patient? When should we intubate the patient? Should it be an awake intubation? What drugs should we use? So we are already trained on the critical thinking that goes into placing an ET tube in. So we should also be trained on the critical thinking that goes into taking the tube out. If we can put the tube in, we should be able to take the tube out.
So I hear what you guys are saying, but I'm going to argue against this because from a program director's angle, from a administrator's angle, I'm going to look and see, are we actually trained to do extubation in the ED? Extubation is a skill. It's a procedure, just like any other procedure. And it's a perilous time when persons get extubated, right? We have to do some post-extubation monitoring and make sure they don't have to be re-intubated. And currently, our training standards, our model of EM practice, if you look at Centinelli, you look at Roberts and Hedges, you look at Rosen's textbooks, very little is about extubation. We set up our procedure labs throughout the years for residency, 3-year or 4-year program, depending on what we're moving to. I don't know. But we always talk about intubation and airway management. We have a lot of things talking about airway errors and what we're doing wrong with intubation and how to better improve our intubation. We developed a lot of technology in terms of intubation. But how much time does a program or anybody really spend in extubation? There is one specialty who actually does spend time in extubation, and that's critical care. Those are the people who probably should be extubating patients and probably not routine practice in the ED. And like Chidi was talking about dispositions, our dispositions, we are the masters of dispoing people, whether it be to the ICU, to step down, to the floor, to home. If we extubate these people in the ED, now we're going to complicate the disposition. We've already admitted this person to the ICU. I like to always be dispoing, as we told our residents. If we already have this person going to the ICU, they already have consultants on board, now I have to recall them and maybe get another disposition for the same patient. I don't get paid for 2 dispositions. I get paid for 1.
All right, Kene, my Nigerian brother. All right, let's talk. Let's level. I have one question for you. Why are you so scared? What are you so scared about? As ED physicians, I feel like you're limiting our breadth of knowledge and practice. I feel like we shouldn't be running away from procedures and protocols that are unfamiliar. We should be moving towards that. That makes us better physicians, practitioners, and it makes us better resuscitationists. For example, how many times did you get trained on thoracotomy, ED thoracotomy? In residency, I got trained maybe 1 or 2 times. I did no thoracotomies as a resident, but my first month as an attending, I did multiple thoracotomies. So in the same thinking, if you're telling me, oh, because I wasn't trained extensively, I don't have experience on how to do these procedures, I shouldn't do that, I would never have done a thoracotomy. So I think you're limiting who we are as EM physicians, and I rebuke that limitation. I rebuke the fear. And also, let's not forget that being intubated and remaining intubated is not without complications. There's a lot of complications such as ventilator-associated pneumonia. So if these patients are staying intubated and they don't need to, you're opening up the window for complications, for mortality, for morbidity, and we don't need to do that. So let's stop the fear, be brave, and let's do these extubations.
It's hard to argue with somebody that's probably done more thoracotomies in a month than I've done in my career, but I'll try. I do think a key to emergency medicine success is our adaptability, our willingness to take on these new challenges and to own them. But I got to look at this a little bit differently. When I'm in the ICU, I've got a whole team around me. It's not just about me learning those new skills or taking on those new skills. It's about the team that surrounds us. And in the ICU, I can extubate somebody and walk away. In fact, we have a protocol where our RTs can extubate independently of us because we put that much trust into our ICU team. So that team is constantly watching. I've just extubated them. Are they failing? Can I prevent failure? Can I anticipate failure? And they'll come get me when I need to be involved. In the ED with our bare bones staffing many times, I just don't know that we can accomplish that same thing, or that the rest of our team is always willing to take on that burden of monitoring somebody after extubation. And talking about failure, in the ICU, I can enjoy a failure rate of 10 to 20% of extubations, and that's considered good practice. Could you imagine in the ED if I extubate someone, I walk out of my shift, I go home, I think I did a good job, and then my colleagues are having to come in 6 hours later and reintubate them? I think they're going to have a problem with that. And then, in my experience, those reintubations are always harder the second time around. The airway might be swollen, the patient's physiologically sicker. It's never easier the second time around. And I see some quality-minded people in the room, some quality directors and people that would love to email us and be like, what the heck are you doing extubating people, reintubating them? What are you doing? So I think we need some good data, which I don't think exists, unless, I don't know, you all can surprise me, or at least a good protocol or a good policy statement to support us in doing this for if we begin to do this routinely. We need something to back us in case failures happen, but I just don't think we're there yet.
I'm so glad you brought up the literature, Skylar, because I just happen to have a slide on this. I'm sure, but you didn't know it.
Better be good.
It's really so. Yeah, it is. So you mentioned robust literature. Well, no, actually, we don't have like robust literature. I can't make that claim. But what does exist? Let's go through very quickly. This is a study on a very super subspecialized group of patients. Those are trauma patients that presented to a trauma ED. 50 of which over a period of time. How many of those got reintubated within a 50-hour period after being declared of having no injury? Well, 0 in a 24-hour period. Again, 50 patients in a very super subspecialized ED. Well, what about another super subspecialized ED ICU? Much bigger cohort. Maybe there's even somebody in the crowd that works here at Michigan. In this group of, let's say, ballpark 150 patients, that were not extubated for compassionate purposes. So patients who were extubated to continue on with their clinical course, 0.5% of those patients were reintubated within the time frame of 24 hours. So that's, again, more data for a very super subspecialized, very intensive care minded ED. But what about the flip side to this argument is what Skylar and the rest have alluded to here, which is that if a patient has to be reintubated, it tends to be a very much more complicated intubation procedurally speaking, and that's undesirable, as you can imagine, making something that's already a dangerous procedure maybe more dangerous. And they also potentially suffer longer hospital courses, longer ICU courses, and then of course the human expense that goes into that, and the hospital expense that goes into that. But what about like a regular ICU? Now, what I'm going to talk about from here out is unpublished. I'll be talking about it later tomorrow at a regular kind of like poster session. But this is a regular emergency department. It's no mistake that I put on my own. This is my place that I work because we have a mixed milieu. We have a mixed acuity ED. There's nothing super subspecialized about where I work, aside from having some critical care tilt to it in terms of faculty. But these are our numbers from looking backwards on a 1-year period. 28 patients of which we extubated, and it wasn't just the critical care team, it was the whole group that extubated. We had 2 patients that were reintubated that had previously been intubated for these reasons. 2 patients reintubated within a 48-hour period. One of those patients was reintubated because they had to undergo a procedure, and the other person was reintubated because they were found with drug paraphernalia on the floor. So tough to predict that kind of stuff. But this all kind of leads me to the next question that I have for the group, which what is the optimal patient population for ED extubation?
These are all good points. I agree with everything. my faculty up here, but I think the optimal patient population to extubate in the emergency department are patients that are intubated for airway protection. So that's the big patient population that I think it's safe to extubate in the ED. If they're intubated for hypoxemia, severe, hemodynamic instability, these are patients that are not going to get better in the short course of 4 hours or 6 hours or however long it takes to get an ICU bed in your hospital. So it's really going to be your altered mental status, intoxications, concern for status epilepticus. Obviously, they can't be seizing when you extubate them. And then the other patient population, it's a much smaller one, but it's the procedural. So short-term procedures. I intubated the patient because they have hematemesis. They were protecting their airway, but GI really needed to scope them. Well, guess what? They scope them, they band them, they clip them, they do whatever. Once your procedure is done, if that patient's back to normal, we can extubate that patient in the ED and potentially just get them to a medicine bed as opposed to an ICU. And then there are three things I think about when I think about, are they ready to extubate? Are they awake, spontaneously breathing? Are they on low ventilator settings? So they have to be on, FiO2 less than 40%, pressure support. And then did whatever I put the tube in, whatever reason I put the tube in, resolve. And then lastly, they can't be a difficult intubation. I don't want to, put that on the ED staff, extubating somebody that was really difficult to get the tube in.
That's fantastic. Okay, so what's the flip side of this question is who's somebody you'd be hesitant to extubate in the ED?
Yeah, the patient population that I'd be really hesitant to extubate in the ED would be patients in shock, especially undifferentiated shock. Those patients may need some additional treatment before they get extubated. So I'd be hesitant to extubate people in shock. Also, I'd be looking and seeing, is the deficit, that the reason that they got intubated in the first place, has that been corrected, like Raghu said? And is the clinical course, is the expected clinical course expected to be prolonged? Are they expected to be critically ill for their projected clinical course? Those are people that I would not want to intubate or extubate in this setting. Also, of course, people with difficult airways, so it can be an anatomically difficult airway, such as congenital, or they've had some surgery to their face, chest, neck. Those people probably wouldn't want to extubate those patients in the ED. And then also the physiologically difficult airway, which goes back to shock. We may want to do some more treatment. We may have to treat their hypoxia. We may have to treat their hemodynamic instability. Those people would be people that I'd be hesitant to extubate in the ED at this point.
I love that. I think I totally echo everything that's been said so far. So let's kind of take it to our last teaching point here and make sure that we have time for questions. This is my colleague, Greg Wu, who's not here, but he helped me develop the following. So these are Wu's rules of safe ED extubation. Let's talk about a protocol quickly. This protocol, by the way, is available in the app, so don't feel the need to take these slides down exactly. So when we're looking for, what we do at Albany Med, when we're looking to extubate a patient or see if they're ready for ED extubation in the ED extubation in the ED, is we look to see if the patient is ready. And there's all these steps that go into it. Everything's already been said here. Like, are they hemodynamically stable? Has the insult been resolved? Is their FiO2 improved? Are they in minimal settings? And I personally like to say, hey, did they have a cuff leak? I like every duck to be in a row here. I like to make sure that everything is aligned up so that they are absolutely ready. I'm absolutely sure I'm giving the person the best possible chance. And then what I like to do is to do a spontaneity trial for step 2. That's spontaneous awakening. Make sure that when they're off sedatives that they are in fact waking up and following commands. And then a spontaneous breathing trial. Make sure that you have an RT at the bedside. They're putting them on a spontaneous breathing trial mode, and give them some time, maybe even calculate a RISB and see how they do from a breathing perspective, so they're not going to be immediately reintubated when they're off of support. Step 3, and this is super important, and it seems kind of humdrum, but it's like making sure that they can manage their own secretions here, making sure that they have minimal secretions when you inline suction, make sure that when you suction above the glottis, there's not something that's coming out in quite a bit of stuff that's coming out above the glottis. And that they're probably going to be able to manage their own secretions when the tube is out in the form of having a strong cough and like that. And then finally, obviously, preparing to actually extubate. And this is important, to walk them through it, sit them upright, talk them through the things you're about to do. And then when you do finally pull the tube, I would encourage you to pull both tubes. OG tube is often in place, including the endotracheal tube and OG tube. And then finally, I like to put them on humidified oxygen. That's for comfort. And maybe, it also reduces post-extubation swelling. And then I can't emphasize this enough. These are not patients you get to ignore afterwards. You have to circle back on this patient pretty consistently at a minimum for the first hour, but probably for the remainder of their course while they're down in the ED, because these are super high risk patients, right? It'd be the worst thing in the world to have to extubate somebody and then ignore them and have them arrest because they were kind of just like stuff in a corner. So here's the actual like very visually stimulating protocol that we have. Again, this slide is in your is on the app, and so feel free to take a look at it. And so in summary, I hope we've given you some ideas here to maybe take back to your next shift with you. Maybe you weren't considering doing ED extubation, and maybe now you will. And the next time that you're faced with that patient who's looking at you and pointing at you, like pointing at the tube and looking right at your soul, maybe you'll consider not putting that person to sleep and sending them to the ICU and making it their problem. Maybe you'll consider doing it yourself. So thank you all. I think we have, hopefully we have time for a question or two. Anybody at all? Yes, great. Not you, Marshall. Sure. I mean, I'll offer quickly. I mean, I think that ED nurses are well trained to see bad, even if just that dichotomy, bad, good. Stridor is one of those things that probably everybody knows is bad. And so to that end, I think that they're good. They're equipped to reassess whether or not they end up having the bandwidth to do so. I think ultimately becomes a question. But do you guys have a different?
I think that I'm not really against this. I'm just arguing that point. But I think if you talk to all your experienced ED nurses, they know when somebody's in respiratory stress, right? So I think that their evaluation in the post-extubation period is basically the evaluation in the pre-intubation period. And if you kind of structure it like that, they're not necessarily learning a new skill, but they're learning, hey, when this person in respiratory distress, after I pull this tube, is it like this person needs to be intubated? Then that might go a long way in terms of allaying their fears and bringing some comfort to them.
I guess I'll show my cards too. I mean, I think this can be done. I think you have to prepare for it, kind of like we're saying. I would say my concern is not that our ED nursing colleagues could recognize this. I'm not sure that they're staffed to do this, and I'm not sure that they're in tune with the prevention that our ICU nurses are, right? Our ICU nurse will go in and say, oh, this person's in pain. Let me get them pain stuff. Let me get their incentives spirometer. Let me do airway clearance. Let me grab the RT. I think high flow nasal cannula. I think they're just more in tune with seeing that. They see reps. They see this all the time. So it's not that they can't do it. I just don't think that they'll have the same level as an experienced ICU nurse that could really help with that prevention piece of it that I think our ICU colleagues, RTs, nurses could do.
Yeah, and just to second that, I don't recommend doing this without having a protocol in place, training. Don't do what I did the first day is show up and like, hey, we can take the tube out. That didn't go over very well. Yeah. But exactly what Keeney said is it's really a skill set they already have. If you just reframe it as, look at the reasons why you put the tube in, when patients are not intubated is really what you're looking for in that extubation period. And then again, I think patient selection is very important. It's really that altered mental status, intoxicated patient, because they won't need, potentially they shouldn't need humidified oxygen, high flow, and all these things, interventions afterwards. But I think having a well-defined protocol that you roll out with the nursing buy-in is going to be very important to doing this.
Yeah, I think nurses do really, really well with protocols. So they love the if this, then this, if this, then this. So if you go to your nurses and say, hey, this is our protocol. They love protocols. If you go to them and say, this is our protocol, I think a lot of people would be like, okay, I have a safety. I have a rescue. They love to have something so they don't have to always call the attending. They don't have to always call the residents. Again, I will say, this is something that you do have to look at your staff too, right? This is not something that you do with the nurse that everybody doesn't want to work with. This is not something that you do with the nurse that you're like, eek, who's working with me? Oh, no, that's not the person that you're doing this with. This is with people who you trust, that you've seen work with critical patients, that you've seen, has that kind of like, oh, something's not right here. That's who you want to do this with.
Okay, oh, yeah, sorry. No, not Marshall yet. You, yes, sir.
Thank you so much for the talk. Working around the spontaneity trials, it's been a while since I've been in the ICU. I remember conversations on extubation, preparing the patient for these trials. They take a while, like more than something to be done in the ED on a regular basis. But I'm just wondering, how long are you running these spontaneity trials? Is it abbreviated compared to what would be in the ICU? Is that safe?
Our trial, we were when we protocolized this, it's 15 to 20 minutes, realistically speaking, maximum 30 minutes. And it's like sometimes you're like, oh, I go and I do something else and come back, and you're like, oh, they're still on. I forgot they're still on the like spontaneous breathing trial, and they look good. So probably time to extubate. Hopefully, there's always an RT there. I don't like just leaving them in the room, but I don't know if there's any other thoughts.
Hi, Nick. How you doing? Yeah, it's abbreviated for the answer to the question. So no longer than 30 minutes is what I do.
Yeah, and then just to as you know, to bring this into perspective, anesthesiologists do this every day, right? And so these patients are not intubated for 2 weeks, and that you're trying to extubate. Very different in an ICU extubation. So I'm really focusing on this frame of patient that's like I've been intubated for 4 to 6 hours, right? So you can do like a 15-minute trial.
Marshall, I'm gonna let you talk.
No, the only quick thing I was going to mention or ask you is that, everybody works in a different type of emergency department where, boarders are still emergency patients. Where I work, once they're admitted to the ICU, they may still board in our critical sort of vacuum area for a long time, maybe like 25, but they're no longer an emergency patient after we admitted them. And I know that in Albany is maybe a little bit different. So if you're at a place where they're no longer your patient, I don't see how you're not holding on to patients for 12 or even if they're no longer your patient. So,
Yeah, that's a great question. It's obviously not my circumstance, so I wonder.
Yeah, I guess it's a good point, and that's how our tertiary care center it works that way. So if I'm in the ICU and I accept somebody, I generally will take over their ownership if they're there for more than an hour or two waiting for an ICU bed. What I will say is we do sometimes have boarding at some of our rural sites, right? The community access site that might have intubated somebody for some reason. They might have to wait 12 hours for the crew to get there, depending on weather. I live in Vermont, so it can take a long time or until a bed becomes available. So even I do wonder about that, right? So I intubated somebody for status last night, and this morning the person Alex describes pointing at the tube, and they're waiting for a transport crew that might be here in a couple hours. Well, maybe there's some role for that too at outlying places that are awaiting an ICU bed for many hours. If somebody wakes up, maybe we. What's that? Exactly. Well, exactly, right. And not only that, I mean, think of it from the perspective of what's the next patient coming in, right? So this person's well, they're not that sick. I'm going to tie up a transport crew. And the next person that comes in, I might need to get out of here ASAP, and I can't because my helicopter's in the air with my mildly critically ill intubated person. So I think this is something we could be, we could take on and be creative with.
Yeah, and I think it kind of we talked about this as part of the panel. This is like it kind of starts with the EM education and kind of ownership that this is something that's in our wheelhouse, and it's not been we have not previously put this in our wheelhouse. It's totally doable in a certain select group of patients, and it's just takes training and we're probably way over time here. So sorry to have taken all your time. We're gonna run, but thank you so much for your attention. We'll be around for.